We're pleased today to speak with Dr. Robert Beart, past president of the American Society of Colorectal Surgeons, who currently practices here in LA. I'm happy for you to be here, Bob. Can you tell us how you got interested in colorectal surgery?
Dave, I appreciate the opportunity to share these things with you as well. I actually trained at the Mayo Clinic in colorectal surgery, but before that I had trained as a transplant surgeon at the University of Colorado and went on the staff at Mayo Clinic as a liver surgeon. And I had been there a year or so, and I realized two things. First of all, they had a number of liver surgeons. So I was fourth or fifth in line, and they put me in a hospital that didn't have angiography, which made it hard to do that surgery in those days. The second thing is the clinic had been trying for a number of years to evolve from proctology to colorectal surgery. They had interviewed a large number of people, none of which seemed to work out, and so I volunteered to become a colorectal surgeon, go back and get training and work in that area, really based on the people that I'd met there.
Mm-hmm. And where did you do training at?
I did my training at Mayo Clinic, and as I said, the people that sort of influenced me, I didn't have a role model for this in residency. I think in those days there were very few colorectal surgeons in academic setting. But at Mayo Clinic there was a proctology department which had been there forever with many distinguished members. And then there were a few general surgeons that did most of the colorectal surgery, notably Ollie Beers. Mm-hmm. And when I first went to the Mayo Clinic, the first thing they did was put me on his service for 3 months to sort of indoctrinate me in the Mayo way of doing things. And, you know, it was great. I mean, I saw colon surgery done in a way I'd never seen it before. It sort of opened my eyes.
Bob, can you describe your initial, maybe subsequent experience with the society?
I think my first experience with the society, I think it was a San Diego meeting. Mm-hmm. And I presented a paper on ulcerative colitis and its risks of cancer. George Block from the University of Chicago had come out and said that there was not an increased morbidity or mortality associated with cancer superimposed on ulcerative colitis. We reevaluated the Mayo data and came to the opposite conclusion. It was sort of a fun paper to do and figure out why they figured out what they came to the conclusion that they did and why we came to the conclusion that we did. And that sort of got me going with the society. And then after that, it just sort of evolved. I liked the meetings, attended them regularly. I think a lot of people don't attend meetings regularly, but by attending regularly, I think I started to get involved, got on some committees, and gradually evolved to the council and then to some leadership positions.
You mentioned Dr. Beers. Were there other people that had an influence or mentored you during your career?
Yeah, I think at that time, Oliver Beers from an abdominal standpoint, and then Bob Spencer, Clyde Culp, and Mark Anderson. Bob Spencer was the head of the division of proctology, which had been a long-standing and really a sophisticated practice. And I think they showed me that anal surgery is not something to be relegated, mm-hmm. You know, to sort of the back of the room. It really is important and it can be done well, perhaps differently than I had ever seen it done in my general surgical training. So those were the guys that really, I think, mentored me, but more than that, inspired me and to, you know, pursue this subspecialty.
Now, you've had a long and distinguished career. What would you say was your greatest contribution?
I think probably a couple. I think from the standpoint of the society, I think when we converted the journal, which when I took over the journal, we were paying $20,000 to $40,000 a year to have it published, and at that time, executive administrators who became our managers for many years, our administrators for many years, helped me negotiate a contract where actually we began to make money, mm-hmm. substantial money. And I think since that time, it's literally been hundreds of thousands of dollars of money a year that has come to the society. So I think from the society standpoint, that might be the biggest contribution, although there were some other things we did with getting strategic planning started and so on. From a clinical standpoint, you know, others could probably judge that better than I can, but I think the work we did on continence preservation Ileoanals, coke pouches, continent ileostomies, and then coloanals were probably, from that standpoint, important. And then we sort of, when I was president, laparoscopy was just coming along, and we initiated the first registry and generated 1,100 cases in a short period of time, and that really became the foundation for the cost trial. And I think getting that started when I was president was probably another important clinical contribution.
You worked at a number of institutions over the years, which is give you maybe a better perspective. What's the difference between, say, the Mayo Clinic, university settings, private practice?
Yeah, I mean, I think it's really, first of all, it sounds like I can't hold a job, but it wasn't quite that bad. I started at Mayo Clinic Rochester, and they had a policy of only being in an administrative position for 10 years. And I was in that position, so by my early 40s, I mean, I was out of an administrative job.
It's the downside of peaking early.
So I went down to Scottsdale, and they really had a different model, and it wasn't the Mayo Clinic model that I had come to know, and I really didn't like that. So I moved to University of Southern California, and then for the last 5 years have been in private practice. I mean, they all have their advantages. These large clinics, I think, are really unique, and they're a quick way to generate a large number of cases and become competent, I think, early. You don't enjoy probably the peaks, and you don't enjoy the valleys of financial income, but there's security, which I think is worth a lot. And I think there's a flexibility to do research and education, which is much more difficult in other environments. I like the university environment, but every university is different. You can't just say, I was at a university and somehow that means something. Ours was very much an environment where you generated your own income and then you had to pay for your expenses. So in many ways it's private practice. But I enjoyed that. And then private practice I in many ways like the most, because I think you have the most flexibility, and therefore I think the financial rewards are the greatest, although it's not necessarily the most secure. So I think they all have their advantages. Much harder to do research in that environment. Still possible in the private environment, I mean, but it was easier in the others. So I think they're all great environments, but I think they are different, and when people look at it, they ought to recognize that.
Where do you see the society going in the future?
It's really a good question. And, to some degree, the society is going to have to react to the environment, whether it's financial or technologic, we have to be reacting.
Well, certainly we've seen that in the journal. There's been some changes in the journal, and that somewhat echoes the pattern of the society. Where do you see the specialty itself going?
I mean, I think it's a great specialty for a number of reasons, and I only see a bright future, mostly because there are a lot of cases out there that are done by non-specialty members that I think over time will drift into the specialty. So I mean, I think there's a great opportunity for growth from that standpoint. I think we've just scratched the surface at doing research. So I mean, if people really want to get into serious motility, absorption, neoplastic development research and so on, I think we're a great specialty, a great area for that. And I think it's unique. It's really rewarding in terms of not only length of life but quality of life issues. And so I think from all those standpoints, it's an attractive specialty, and I think we'll just do well.
So if a young colorectal surgeon came to you and said, I'm interested in doing something in society, how should I progress my career?
Well, first of all, they do. I mean, and that's encouraging. I mean, I think there are a lot of people that want to be involved. I think the society recognizes that. And every time I've brought a name forward, whoever is president or whatever has been very good about getting them into committees. So I think that's the way you start. Unfortunately, I think most people like to get on the committees, but then they don't go to the committee meetings. And I think it's really important that if you're going to want to get involved, I mean, you've got to play the game by the rules. I mean, you've got to be attending meetings, you've got to be attending committee meetings, and you've got to be publishing a little bit, I think, sharing your thoughts. And personally, I think if you do those things, your involvement is automatic. I mean, I don't think there'll be any question that you will gravitate to positions of responsibility within the society. And I say that largely because so many people don't. So I feel strongly that there's a lot of opportunity here for people to do that.
Okay. Is there anything else you'd like to add?
Not particularly. I mean, I think I alluded to the fact that I think I made a very, very good decision from my standpoint to get involved with this specialty. I do think in terms of the age spread of patients that we deal with, in terms of the quality of life, quantity of life, quality that we deal with, those sort of diseases, the opportunity to take care of people who are sick and minor illnesses and outpatient, inpatient. I mean, all those things are so variable. There's not many specialties that are like that. I think it's really attractive. I think people should, look at it seriously. I think it's a good quality of life for the doctor, and I think you have a lot of patients that are very grateful.
All right. Bob, I appreciate you spending your time with us and sharing your thoughts. Thank you.